It's my pleasure to present on behalf of our study group, AGMT, a randomized phase 2 trial comparing KTT with KRD for induction therapy, followed by a second randomization to carfilzomib maintenance therapy versus control for 1 year. So we included a total of 123 patients, and patients were, of course, the median age of our patients was 75 years, so it's an elderly, non-transplant eligible patient population. And by doing so, we obtained, by using this regimen and administering for 9 cycles, we achieved a response rate of almost 99% in the KTT arm and of 88% in the KRD arm, which is remarkable. And then the rate of very good partial response or better was 77% in the KTT arm compared to 65% in the KRD arm. We also, of course, assessed MRD status in 60 patients after 9 cycles of induction therapy. And the MRD-negativity rate was 39% in those patients who received the KTT arm, thalidomide-containing arm, and 59% in patients who received KRD. So when we look at the overall response rates we have discussed, and then move forward to progression-free survival, there was no difference in progression-free survival between both groups, and there was median progression-free survival was numerically slightly longer, 34 months in the KRD arm compared to 25 months in the KTT arm, but there is no significant difference by log-rank test. Overall survival was similar in both groups. It was 52 months in the KRD arm and not reached in the KTT arm. And then when we looked at progression-free survival and overall survival according to age, there was no difference in PFS, similar in patients aged 75 or older as compared to those younger than 75 years. But when we looked at overall survival was significantly longer in the younger population. We also looked at outcome in patients with cytogenetic high risk. Just focus on patients with translocation 14, 16, and deletion 17p. We did other analyses as well. But what we found is that there was a significant difference both with the KTT and with the KRD arm between cytogenetic standard risk and high-risk patients in terms of PFS, but overall survival was not significantly different at this point of time. Now, the maintenance study is interesting because 72 patients have been randomized to maintenance, which means carfilzomib twice per month for 12 cycles for 1 year versus control. And there was a numerical but not a statistical significant improvement of PFS by carfilzomib maintenance therapy. For overall survival, the data are not mature enough. Now, what we also did is we looked, and that was done in Bruno Paiva's laboratory, we looked at the immune score at baseline in order to figure out whether that has an impact on outcome. And actually, a high immune score was associated with impaired outcome, with lower PFS, and so significantly lower PFS, but the OS data are not mature now, but there was a tendency for lower overall survival rates in patients with a high immune score. Now, when we come to safety, there was more thrombocytopenia, grade 3 and 4 thrombocytopenia with KRD. There was more neutropenia with grade 3 and 3 with KRD. And regarding other non-hematological toxicities, there were significant differences between KTT and KRD. There was particularly more, there were more severe cardiac disorders with KRD, but there was more diarrhea with KRD as well. And then with KTT, we had more dizziness, more neurological disorders, more edema, more peripheral neuropathy, but mainly grade 1 and 2, more thromboembolic complications and upper respiratory tract infections. So with that saying, I would like to conclude that KTT versus KRD was found to be non-inferior. The overall response rate was quite significant with both regimens. This was the intent to treat analysis. VGPR rate was 77% in patients with KTT versus 65% in those with KRD. MRD rates I mentioned before, 39 and 59% respectively. And PFS and OS were similar in both groups, and patients with higher age had similar progression-free survival compared to those younger than 75 years. But overall survival was shorter, was shorter in patients, in elderly patients as expected. And discussed the impact of high-risk cytogenetics, which impacted on progression-free survival in both arms. Maintenance therapy with carfilzomib showed a numerical but not significant improvement in PFS, and a high immune score correlated with shorter PFS. And toxicity profile was different between both arms.